Today is 1st of April. लेकिन ये April Fool नहीं है. This is a serious academic activity. Welcome for all the respected delegates and dignitaries who have joined. Our journal journey is a monthly academic activity which is very popular, and the credit goes to our mentor, Dr. Nimen Mohanty sir, who finds a topic which is recent, relevant, and helpful for day-to-day practice of the pediatricians of periphery. We are also thankful to Dr. Hemant Gangolia sir, Dr. Ramakant Patil sir, Dr. Ram Gopal, Dr. Amol Pawar, Dr. Jay Bhandarkar, and Dr. Vikas More, our Maha-IIP presidents and the Raigad IIP presidents. Our journal journey has come into the mainstream activity because of them. Now I invite Dr. Neha Singh, who is the backbone of all online activity, an active Raigad IIP member and our editor, for welcoming all the guests. Dr. Neha.
Thank you, Chitra ma'am. Good evening, everyone. I, Dr. Neha Singh, on behalf of Maharashtra Academy of Pediatrics and Raigad IIP, welcome all the respected dignitaries, seniors, and colleagues for today's journal journey. I welcome Maha IIP President Dr. Ram Gopal Chejara sir and Dr. Amol Pawar sir, and as well as all the respected executive board members of Central IIP and Maha IIP. I also welcome Raigad IIP President Dr. Vikas More sir, Secretary Ajay Kohli sir, Dr. Hemant Gangolia sir, Dr. Jitendra Gawani sir, and our patron Dr. Nimen Mohanty sir, as well as Dr. Jay Bhandarkar sir, Dr. Chitra Kulkarni, and all the members from Raigad, Navi Mumbai, and other branches. Today's session has been granted 1 MMC points, so requesting everyone to type their name, MMC number, Central IIP, and city in the chat box. Today's session of General Journey, we have with us Dr. Ramakant Patil sir as our MMC observer for today. For today's session, we have two experts, Dr. Upendra Kinjewalkar sir. He is immediate past president Central IIP. Welcome, sir. And Dr. Sanjay Mankar sir, who is consultant pediatric infectious diseases, Bharati Vidyapeeth Medical College, Pune. Our two presenters for today are Dr. Narjohan Meshram sir, consultant pediatrician and intensivist, Apollo Hospital, Navi Mumbai. His topic is association between dietary fiber intake and cardiometabolic risk factors in adolescents. And our second presenter is Dr. Sunil Padalkar sir, consultant pediatrician and neonatologist at Panvel, Raigad. His topic is salmonellosis, including enteric fever. Now I request our first presenter to please share their slide. Over to you, sir.
Thank you, Neha ma'am. I will share my slide now. So,
yes,
good evening.
Yes,
so I'm audible to everybody,
Yes,
I think
yes.
so. Yeah. So, good evening, everybody, my dear seniors, friends, and colleagues. Today, I'm going to present topic is association between dietary fiber intake and cardiometabolic risk factor in adolescent. And this is very hot topic now, and it has been taken from the Journal of Pediatrics, published in November 2023 by Jonathan Carboni et al. In adolescent in United States of America. So basically, the impact factor of the journal is 4.4, and we can see that why have we chosen this topic is because of the prevalence of obesity is increasing in India, and in Navi Mumbai the prevalence of obesity is around 11 to 12%. Why it has been happened? Because of westernization of Indian diet, there is an increase in obesity and cardiometabolic risk in adolescents and early adults. So, what are the cardiometabolic risks? Is hypertension and obesity, increase BMI, increase serum uric acid level, or microalbuminuria, like that. So, no pediatric study had been done till now on this topic, and most of the data on this topic is extrapolated from the adult study. So that's why the study is the discussion of study is important. So here we'll discuss some background about this study. Basically, dietary fiber are indigestible portion of the plant product, which comes from whole grains, fruits, vegetables, as well as legumes. So in this study, they put a hypothesis that these dietary fiber have a combined effect with the gut microbiome and host immunity. So key metabolites of the dietary fiber interact with the gut microbiome, and that produces the mucus layer in intestine. So that prevent the translocation of the intestinal bacteria into the epithelium of the intestine and likewise in blood. So another hypothesis over here is dietary fiber curtail the overall energy intake and produce its hypolipidemic effect. In adults, it has reduces the hypertension and associated mortality that has been proved. So we will discuss here the study abstract. What are the objective of this study is the association of dietary fiber intake and cardiometabolic risk in adolescent in USA. So in which they took a primary outcome as a blood pressure and secondary outcome as obesity, hyperlipidemia, albuminuria, estimated GFR, and serum uric acid level. So how they designed this study is they included the age group of 13 to 17 years on the basis of the National Health and National Nutritional Energy Survey 2009 to 2018. So it is a cross-sectional study, and it is a picture of health of adolescents and early adults in United States of America. And exclusion criteria, they took a pregnancy, small for gestational age, and major health issues, those who got a major health issues. And they did a assessment by 24-hour dietary recall method twice, and they included these cohort in the study. So what was the result of this study is low dietary fiber intake associated with the increased diastolic blood pressure, BMI, and serum uric acid level. The increased serum uric acid level. So conclusion of this study was there was a significant association found in between low dietary fiber intake and poor childhood cardiometabolic risk markers that indicate need of prospective study to establish the further relation. So how they have conducted this study? They took a cohort of 3,827 subjects from 2009 to 2018 on the basis of the national survey, and they took 24 hours dietary recalls of them. So one which was taken in person, and later on day 3 on day 10 they took telephonically. So they divide dietary fiber intake into quartiles, like no dietary fiber intake, low dietary fiber intake, moderate dietary fiber intake, and recommended dietary fiber intake. As well as they model this study in crude model 1, 2, 3, by which they have refined this study by using adjusted linear and logistic regression analysis. They have taken the average of 2-day intake by 24 hours dietary recall method as a continuous variable, and they have averaged it and adjusted according to the age and weight of the subjects. So here they took a primary outcome. So what is the effect of dietary fiber on their blood pressure? So for which they took at least 4 measurements, and they have averaged it to decrease the bias. So they defined hypertension in adolescent like systolic blood pressure is more than 130 and diastolic blood pressure is more than 80. They took as a hypertension. Whereas pre-hypertensive phase, they divided the readings in between 120 to 129 and diastolic BP less than 80. So what are the secondary outcome? Secondary outcome, they took into consideration of BMI more than standard deviation and lipid level, serum triglyceride level more than 130, high density lipoprotein less than 40, and low density lipoprotein more than 160 milligram per deciliter respectively. So they have defined this hyperlipidemia on basis of these values. Second, urine albumin and creatinine ratio, which is more than 30 milligram per gram, has been considered as a microalbuminuria, and estimated GFR more than 140 ml per minute per 1.73 meters square has been taken as a hyperfiltration. Likewise, we conduct this kind of study. Always there are possibility of confounding factor. Confounding factor means these are the factor directly or indirectly affecting the study results. So the major important confounding factors over here are family income and poverty level ratio. If child family income is low and family income is low and there is poverty, definitely it is going to affect the diet of the children. And food insecurity status as well, and passive smoke exposure. They have defined passive smoke exposure. At least one member in the family should be smoke in household to call it passive smoke exposure. So this is the flow chart of cohort selection. So National Health and Nutritional Energy Survey 2009 to 2018, they took a subject around 4,186 subjects. The age group more than 12 years of age and less than 18 years of age, majoritarily adolescent population, and they have excluded low for gestational weight babies. Those were 9. So, and other exclusion criteria, pregnancy and major comorbidities were absent in this cohort. Total adolescent patient they take into the consideration is 4,177, among which there was no data available, dietary data available for 350 cohort. So total number of subject they arrived as 3,827 subjects. So in which they took a secondary outcome as a obesity data. The available data were for 3,800. For BP data, the number of subject available for 3,721. For dyslipidemia, it was 1,901. For albuminuria, it was 3,747, and GFR, it was 405. So likewise, they studied and they found that the mean age of enrollment was 15 years, and it was equal distribution among the females and males. So they found that dietary fiber intake was lower as a greater age of enrollment, and in females, those who got a higher BMI, and non-Hispanic blacks and poor family. The p-value was significant over here, which was less than 0.05. So as the age of enrollment increases, dietary fiber intake was decreasing. In female, those got high BMI and food insecurity, and on the basis of race and ethnicity, the non-Hispanic black has the lowest consumption of the dietary fiber. So in which they took a demographic characteristics like dietary fiber, male sex, BMI, and all, food insecurity, blood pressure, and all. So for categorical variables, they took a consideration of the percentage over here, and whereas the continuous variable, they take a mean of the value over here. This is mean and standard error. So there is no statistical significant association were found between dietary fiber, microalbuminemia in any model of the study. Significant association found with a low dietary fiber intake and higher blood pressure and increased total body fat. So in this relationship, they have modeled this study. Model means they have refined the study by addition of the multiple confounding factor. So they have taken a multiple confounding factor in consideration in model 3, whereas in model 1, only age and sex, and model 2, rest of the confounding factor taken into the consideration. They have found that the BMI was affected by low dietary fiber intake in crude model and model 1 and model 2, whereas it absent in model 3. And systolic blood pressure and diastolic blood pressure. Systolic blood pressure only it holds true for p-value hold true for crude and model 1, which was significant, whereas in diastolic blood pressure, it was significantly affecting diastolic blood pressure, those adolescents who are taking low dietary fiber in their diet. So diastolic blood pressure was in decreasing trend, sorry. And cholesterol level, triglyceride, LDL and HDL level were not much significantly associated with the intake of low dietary fiber intake. And whereas urine, albumin and creatinine ratio and estimated GFR was not having any kind of significance with the low dietary fiber intake. And uric acid level, serum uric acid, the crude and model 1 has a significant effect on the serum uric acid level by intake of low dietary fiber. So this is a box plot graph in which they divided dietary fiber intake into quartiles. So this is low dietary fiber intake, moderate, the low dietary fiber intake, low dietary fiber intake, moderate dietary fiber intake, and recommended dietary fiber intake, in which we can see that this is a systolic blood pressure box plot and this is diastolic blood pressure box plot. So as the intake is increasing on x-axis, so the on y-axis the measurement of blood pressure is there. So it is the incidence of the systolic blood hypertension has decreasing over a period of time as they are consuming high dietary fiber in their diet. So relationship between the dietary fiber and dichotomous cardiometabolic markers. So highlighted things are showing the significant association. So if there is a low dietary fiber intake in diet, it will cause obesity, hypertension, elevated blood pressure, majoritarily diastolic blood pressure, and in crude model and model model 1, there is a association of dyslipidemia, whereas there is no association of microalbuminuria and glomerular hyperfiltration associated with the low intake of dietary fiber. So in discussion, uncontrolled blood pressure is a risk factor for coronary heart disease, which is stroke, peripheral artery disease, and chronic kidney disease. In model 3, low dietary fiber association is lost due to the DASH diet. What is DASH diet? Is dietary approach to stop hypertension. So in which they took this DASH diet as a confounding factor. So not solely the dietary fiber has a superiority to decrease the blood pressure. There are other nutrient factors also responsible for the decreasing blood pressure. That was lower ratio of sodium and potassium in diet. Likewise, obesity is also associated with the lifestyle and diet as well. So not only diet is important to reduce the obesity, lifestyle is also important to decrease the obesity. That has been proven in model number 3. So it suggests that DASH diet is having a greater impact than the fiber alone. So other dietary components are important over here that need to be studied. In model 2, dietary fiber associated with the low lipid lowering significance last after adding demographic covariants like poverty, family income, and all. So further investigation are required why it has happened. So limitation and suggestion regarding this study is it is a cross-sectional study basically, and it has a lack of prospective data and follow-up for future risk. So lack of future follow-up is also there. So to count a variable dietary fiber is in the food is also difficult because there is no standardization and there is always room for bias due to the recall method. So prospective study is needed. So lack of inflammatory markers data as well, those who are taking a low dietary fiber supplementation. So we can correlate these markers, ESR, CRP, and ferritin with a chronic diseases. So further studies are required to investigate the mechanism behind the effects of dietary fiber, whether the component is soluble or insoluble. And there is a correlation of long-term dietary consumption of fiber. Its prospective effect need to be evaluated against the chronic diseases. And in Indian perspective, it is very helpful if you know the gut microbiota supplementation and its association with the cardiometabolic risk factor and its association with the dietary fiber intake need to be studied. So this study may help to develop a preventive strategy for chronic cardiometabolic disease, and further study are required to evaluate a specific type of fiber diet, whether it is soluble or insoluble cardiometabolic outcome in adolescent. So my message to pediatrician and researcher over here is these studies can help for implementing the preventive strategy for future cardiovascular risk, and that helps to know the importance of dietary fiber, whether it's a soluble component or insoluble component, and recommended dietary allowance in adolescent, and to what are the mechanism of hypolipidemic effect, anti-hypertensive effect, and anti-inflammatory effect of dietary fiber and its effects on the gut microbiome. So role of dietary fiber help us while formulating the national guideline for adolescent. So that's why this topic is very important and that need to be studied further. Thank you so much.
Please stop sharing. Thank you so much. Our expert, Dr. Upendra sir, is requested to give his expert comments.
Yeah, thank you so much, Dr. Chitra Madam. At the outset, let me thank Dr. Ram Gopal, Dr. Amol, and entire Maharashtra IP team for your kind invitation to be part of this wonderful journal journey, which is started long time back. And thank you so much, Dr. Meshram, for enlightening us, because actually Narjan is a intensivist at Apollo Hospital, and this topic has absolutely nothing to do. He is 24/7 into intensive care, but really, let's give a big round of applause for studying this article wonderfully and analyzing and giving a key messages. I think I represent as a
Thank you, sir.
general pediatrician here, and we want to give certain messages to pediatricians through this article, which is very well studied, though he has given in the end that we need to have more of prospective studies. But I think time has come that we ourselves should understand that the prevalence of obesity is already on the rise, and hypertension also. I remember my days in UGPG days, we had hardly seen any hypertension, which was not secondary to some other cause. Renal was the most common, followed by sometimes coarctation, maybe. But now essential primary hypertension is on the rise. Municipal studies in the municipal schools of Mumbai had shown the prevalence to be of 6%. That's pretty high. So imagine that. So in a classroom of 50 or 100, you can see 6 in 53. That's pretty high. So all of us need to understand certain basic things, and the two parts which are studied here, the role of fiber and cardiometabolic risk factors. So let's understand one by one. Before that, the dietary recall method, which was done 24 hours, Narjan has already in the end stressed upon the fact that that may not be completely right. So there are 3 ways that we do it. There could be a weekend survey, there could be a midweek, and there is a 24-hour recall. Remember, this is the way it is studied. And though the midweek is the ideal one, but then because weekend, some families could have good diet or a very poor diet, 24-hour is the one which is most reliable, because usually you remember everything that you have eaten in the last 24 hours. So what are the most important cardiometabolic risk factors? Let's first understand then, and then we can go to fiber part. So obesity, obviously, which is on the rise, and we calculate and we relate obesity only to BMI, but the time has come that we need to put more emphasis on skin fold thickness, probably, and central obesity is much more common. So waist circumference will come in a big way in a year or two, not very far off. Those of you who have started, actually, we do have our waist circumference charts by Dr. Khadilkar. Start using them, and central obesity is the most important point that we should not miss at all. And before that, start plotting the weight of every child. Start taking BP from 6 years onwards. Annual BP is a must, and then putting it. So none of our children should go to obesity without, nobody goes there without crossing the overweight line. So we should pick them up at the overweight line itself. The second point is the other cardiometabolic risk factors. There are about 10 of them. Let's remember, very easy: hypertriglyceridemia more than 110, impaired glucose is another one, and then low HDL, all of us know, less than more than 40 is protective, less than 40 is a high risk. Pre-hypertension or hypertension is another factor, and of course family history, which is absolutely not in the child's hand. So let's forget about that. Smoking and physical activity is another one. Smoking is, all of us know, it's a very high risk factor for any cardiac event later on in life. And if the adolescent has started smoking at 14, 15, or maybe earlier than that, it's tremendous high risk. So let's also take care of that part. And finally, unhealthy diet and renal disorders. So why should I check BP? Not only, you may say, sir, we would check only of the obese children. Not at all. Remember that insulin resistance is generally associated with overweight. I agree. But then not all overweight, obese children have insulin resistance, and it may also occur in lean children. So therefore, hypertension need not be only in obese children. So start making a habit of even lean adolescents. So every child from 6 years onwards, at least the annual BP is a must. He talked about DASH, that is a dietary approach. So fiber is one component which is studied in this, but all of us know that for cardiometabolic health of a child, we need to have more inputs rather than only fiber. So what are the other things? So let's give emphasis on vegetables, fruits, legumes, nuts. I think whole grains are so important, seeds, fish, everything. So poly and monounsaturated fatty acids, we need to talk about that. Now, soluble fiber is important because all of us know that there are 2 types of fiber: soluble fiber, insoluble fiber. Soluble has more role on cardiac protection, where insoluble we have the gut health, which is more important. All of us understand that part. So saturated fat, this is another big no-no that we should take care of that. Ultra processed food. Friends, please understand, I would just take half a minute of yours. All the health related issues of non-communicable diseases have started going up from 1990. And what is common from that onwards to 2024, it's increased consumption of ultra processed food. Every disease, yesterday I shared that the increased prevalence of cancers, colorectal cancers have started coming in 40 to 50, which was not known. It was 50, 60 or later decade. They have come 20 years before. And again, I feel the most important reason is ultra processed food. So some other time we would talk more in detail about it. And high sodium diet is also equally important. We have to reverse it, and some potassium containing fruits are so important. Red meat, please tell your patients to be a big no-no, especially the beef, lamb, mutton, pork. So let's be very careful about it. And for non-vegetarian, one word as pediatrician, we must say, none of the non-vegetarian foods have fiber. So they have to have some sort of salads with every morsel of non-vegetarian food that they eat. Not that all Indians eat continuously. Even if they're non-vegetarians, we do not eat 24/7, all 7 days a week, but let's tell them to have that. And of course, the sugar sweetened beverages, alcohols, alcoholic beverages, and trans fats. And finally, physical activity, sleep are all important factors for cardiometabolic protection. And so maintaining growth chart is very important. Finally, I would spend a minute on talking about fiber. So why Dr. Narjan was talking about how fiber helps in reducing this cholesterol and lipid profile. So EGFR and microalbuminuria, not much of effect they have shown, but definitely there is a role in reduction of BP. And of course, lipids, that is very important. All of us understand that bile is actually made up of cholesterol in liver. It gets stored in gallbladder. All of us know that. And it emulsifies fat in small intestine. And then finally, something we know, intrahepatic circulation, it comes back into blood and goes to liver. But the major portion, if your diet does not have good amount of fiber, everything will go back. Now, there is another huge controversy, endogenous and exogenous cholesterol, how it affects the body's cholesterol or lipid profile. But let's remember that endogenous cholesterol is not released, that there is a negative feedback mechanism is not by your blood cholesterol levels, but it is the cholesterol which is there intracellular, which we never measure. So please remember that. So unless and until child has good amount of soluble fiber in his diet, that cholesterol gets in the bile, that gets trapped, and then it goes down in the stool. So very important. So what kind of immediate in day-to-day practice, what should you talk about? Whole grains are the best sources of fiber. Let's remember lentils, millets. Now, biggest advantage of millets, ज्याला आपण श्री धान्य म्हणतो. So all of them have नाचणी, बाजरी, ज्वारी, you talk it, varai, so rad, you kodu millets, you kangni millets. So these are all there. Have handful of nuts. निदान 20 शेंगदाणे, चणे, कुरमुरे काहीतरी त्यातलं तुम्हाला, you have to have some sort of nuts, seeds also. And which seeds? The chia seeds, the sunflower, pumpkin, flaxseed, muskmelon, sesame, something. And even salad, cucumber is supposed to be best. Amongst fruits, apple has equal amount of soluble and insoluble. So apple is very important. Even banana is great. And you know, there is a difference that fiber gets affected by your cooking process also. So on heating, the fiber amount of soluble and total fiber increases. If you cook it for 100 degrees for 10 minutes or roasting at 80 minutes, Kunamade, where that fiber has good amount of protein. So if it is like soya, which is extremely rich in proteins, on which, so if you do it heating treatment, the fiber amount increases. But on the contrary, in vegetables, if you do too much of cooking, hemicellulose goes down. So we should avoid that. And all the foods that tomato, carrot, cucumber, beetroot, onion, we can have even the raw, no problem. So, but on soaking, again, cellulose and pectin increases. So finally, we should remember that insoluble fiber is for your gut health and soluble fiber is for your cardiovascular health. Healthy gut microbiota. I never lose an opportunity to talk about more and more about it. You have pets at home, so you have dogs and cats, you take care of them. So we must put emphasis on healthy gut microbiota, which can only come from fiber. So though it is an undigested part of fruits and vegetables, it's extremely good. Avoid indiscriminate use of PPIs. Almost all hospitals, I do not know why after ceftriaxone you have to give a pan. Who has said that? Every child who is on ceftriaxone is immediately on some pan. I don't know why. So please avoid doing that. And let's give more of emphasis on good amount of fiber. And of course, a comprehensive advice on all these factors would certainly take care that our adolescents not only become obese, but unfortunately, if they're there, then this dietary recommendation would help them come back to normal track. Thank you so much.
Thank you. Thank you so much, Dr. Upendra sir. तुम्ही खूप छान with example you have told all the dietary fiber, soluble and insoluble. We are really for that. And second presenter is Dr. Sunil Padarkar. He is going to tell us about salmonellosis. I request Dr. Sunil to share his screen. Yes, doctor. Very good. Thank you. Dr. Sunil.
Dr. Sunil,
We
are
can
we
see your
audible?
screen. We can see your screen, but you are not audible.
Is he seen? Sunil दिसतोय का?
Now, he has shared his screen.
Make it full screen.
सुनील ऐकतोयस का तू?
I will call him immediately. Wait.
Up, please.
Ma'am, I requested him to unmute, but I think he is not able to.
नाही पण असं पण नाही की ते बोलतायत म्हणून. He is not started speaking, so probably.
हो सर, त्यांचा हे पण
Yes.
व्हिडिओ पण
Hello.
stop आहे.
Yes,
हा
yes.
सुनील.
Yeah. Yeah. You may put off your camera, but continue your presentation.
So my journal is salmonellosis, including the enteric fever.
सुनील एक मिनिट फुल स्क्रीन ला जा. फुल स्क्रीन. हा.
Yes.
Yes.
So which is published in PCNA volume 69, page 65 to 77, February 2022. Published by 3 pediatricians in Department of Pediatrics and Childhood, the Aga Khan University Hospital, Karachi, Pakistan. This is basically review article. Why we have taken this article to analyze the increasing cases of non-typhoidal salmonellosis and increase in extensive of this journal to brush up knowledge about salmonellosis and to be aware about the increasing drug resistance and prevention, and to be aware about increasing incidence of non-typhoidal salmonellosis. So as you know, the salmonella is one of the significant cause of foodborne disease, and it is a major health problem in worldwide, which is caused by genus Salmonellosis, which is named after the Daniel E. Salomon, who is the veterinary assistant. Dr. Theobald Smith has discovered this organism, and which is named on his honor. It is from the family Enterobacteria. It is a gram-negative bacteria, motile, non-sporulating bacteria. As you say, the more than 93.8 million foodborne infections annually occurred by this disease organism, and more than 2 per year. It is incidence very high in South Asia and sub-Saharan African countries. Is higher than more than 100 cases per 1 lakh population per year, which is the second most common zoonotic diseases in the world. The incidence is very high in low and middle income countries. The Salmonella basically categorized in 2 categories: Salmonella bungarii, which is found in cold-blooded animal, and Salmonella, which is subdivided into the 6 subspecies. Salmonella typhoidal salmonella is causing only human infection, which causes typhoid fever by Salmonella typhi, and paratyphoid fever for Salmonella extraintestinal infection. So also the transmission of Salmonella. Salmonella typhi is transmitted by human to human by contamination in water and food. Other and non-typhoidal salmonellosis is transmitted by direct contact by food animals and vectors, and indirect transmission by companion and wild animals, as you see in the pictures. There are multiple studies have been done for this salmonellosis. In 2016, 2017, and 2018, the conclusion is that there are rising cases of salmonellosis and non-typhoidal salmonellosis over the year. The average is around 9.8% in salmonella disease and 53%, 54% in non-salmonella typhoids. How the disease is pathophysiological. The pathophysiology of the salmonella depends upon multiple factors like infectious species, infectious dose, and the gastric pH. As you see in the diagram, once the salmonella enters the human by fecal-oral route by food and water contamination, it goes to the stomach. When there is a pH is low, the infection dose is decreases. Once it comes to the intestinal lumen, the salmonella typhoid salmonellosis enters the epithelium, breach the epithelium by the penetrating the specialized epithelials called M cells. They engulf by the macrophages. They deposit it to the lymphoid tissue, and from where they are spread to the systemic infection. Sometimes when there is a load is more, it can directly spread by the hematogenous load. And in non-typhoidal salmonellosis, they have only neutrophilic affections. They engulf with the neutrophils and they causes the local reaction. They present with the diarrhea and sometimes dysentery. Now we'll know about the typhoidal and paratyphoidal salmonellosis, which is caused by Salmonella enterica family, enterica, which is serotype causes disease only in humans. It has no known animal reservoir is there. In prebiotic era, the mortality rate is very high. It is about 15%. In post antibiotic era, it is estimated to be less than 1%. The first resistance is detected, multi-drug resistance detected in 1970. Second resistance is detected in 1995 to the fluoroquinolones. And in 2016, there is extensive drug resistance detected from Pakistan, which may be due to the plasmid and chromosomal bond. At present, in 2018, more than 5,000 cases of extensive drug resistance are present. Non-typhoidal salmonellosis, it is usually causes gastroenteritis, sometimes bacteremia, or in some time it is maybe invasive in any young infant or immunocompromised patient. Diagnosis is very difficult to form from other causes of gastroenteritis. Stool culture and blood culture may helpful. It is usually self-limiting. Hydration therapy is required. Antibiotics in severe cases and immunocompromised young patient is required. Third generation is the drug of choice, and sometimes fluoroquinolones can be used. Duration lasts for 5 to 14 days. 10 to 25% case fatality is there. In invasive and multi-drug resistance cases, clinical feature of salmonellosis disease stays from 7 to 14 days, which is a non-specific, mild to severe fever, anorexia, nausea, vomiting, cough, headache, myalgia may be present. Sometimes they present with the complication like intestinal perforation, myocarditis, meningitis, osteomyelitis, and pyelonephritis. Complication rate is 10 to 15%, which is more in extensive drug resistant strains. There are some difference between typhoidal and non-typhoidal cases. The major difference is in typhoidal, there is a carrier rate is very high, more than 1 year, and which is low in non-typhoidal diseases. Typhoidal diseases only transmit from human to human, whereas in non-typhoidal there are multiple factors in poultry, beef, pork is there. Typhoidal salmonellosis causes systemic manifestation, whereas in non-typhoidal causes only some gastroenteritis and extraintestinal invasive diseases. Vaccine is developed for typhoid diseases. and which is underdeveloped for non-typhoidal salmonellosis. How we diagnose the typhoid salmonellosis? There are multiple methods used for diagnosis, which is some serological test. As I mentioned, Vidal test is the most commonly used serological test by practitioners. The test is done to detection of agglutination antibodies to lipopolysaccharide O and H antigen. They have 74% sensitivity and 76% specificity, but there is variable sensitivity has limitation, and need of pair sera is required. They have a lot of limitations. Second is Typhi dot, which detects IgM and IgG antibodies to the outer membrane protein. It has a 70% sensitivity and 80% specificity. But the cross reaction is very much there in Typhi dot test. Typhi dot M is specific to the detection of IgM antibodies. It has a high sensitivity and 82% specificity, but lack of organism and is there. Detection of organism is there. Tube X is detect only antibodies against Salmonella type lipopolysaccharide. It has a 78% sensitivity and 87% specificity. The other method is culture methods. Blood culture is the gold standard method for isolation of species. It is widely used. It has a 40% sensitivity and 80% specificity, but it has a limitation. It depends upon volume of the blood and dose of the infection which is in the blood. Bone marrow is the second culture method used for isolation of species. It has a high sensitivity, but it is very invasive and not routinely used. Stool, bile, and duodenal content can be looked for the isolation of species, but at a very low sensitivity and specificity, and may suggest only carrier stage. The molecular method is a PCR method, which detects amplifying flagellin gene locus, which has a more than 90% sensitivity and 100% specificity, but commercially not available, and it is only have academic purpose. There are multiple why summary of antibiotic resistance salmonella. You can see on the screen, there are resistant strains, multi-drug resistant strain salmonella, which is resistant to the ampicillin, trimethoprim, and sulfomethoxazole and chloramphenicol due to the multiple gene mutation, which is first detected in 1970. Second is the quinoline resistant salmonella strains, which fully isolate resistant to the fluoroquinolines like ceprofloxacin, which is first detected in 1990, and extensive drug resistant salmonella strains detected in 2016, which is resistant to the third generation cephalosporin plus ampicillin and other drugs. They have multiple gene mutations. How the typhoid is treated? They divided into the uncomplicated typhoid fever and complicated typhoid fever. In uncomplicated typhoid fever, if it is fully sensitive, still they are treated with the first line choice of antibiotic, chloramphenicol and amoxicillin for 14 to 21 days. Alternative therapy used for fluoroquinolines. In multiple drug resistance cases, fluoroquinolines or cefixime is the first line of choice for 5 to 7 days or 7 to 14 days. Azithromycin used as an alternative therapy for 7 days. In quinoline resistance cases, the ceftriaxone is the drug of choice for 10 to 14 days. Alternative therapy used like cefixime or azithromycin for 5 to 7 days. In extensive drug reaction resistance cases, azithromycin used as a first line of antibiotic for 7 to 10 days, and meropenem is alternative therapy for 10 to 15 days. In a complicated typhoid salmonellosis, if it is fully sensitive, fluoroquinolone, chloramphenicol, ampicillin is used for 10 to 14 days. Ceftriaxone is the drug of choice in alternative therapy for 10 to 14 days. In multiple drug resistance, fluoroquinolone is drug of choice for 10 to 14 days. Second line is ceftriaxone and cefotaxime for 10 to 14 days. Quinolone resistance cases, ceftriaxone is the or cefotaxime is a drug of choice for 10 to 14 days. Azithromycin is for 7 days. In extensive drug resistance cases, meropenem is a drug of choice for 10 to 14 days. Alternative therapy, azithromycin or meropenem for 7 to 10 days for azithromycin and meropenem for 10 to 14 days. This in contrast with the as study, they have mentioned that this alternative therapy for the typhoid salmonellosis. In contrast to this, I would like to share the Indian standard protocol for the typhoid fever as a guideline published in 2022 for standard treatment protocol treatment guidelines for typhoid fever in 2022 that for the choice of empirical therapy in India. Still, it depends upon patient's condition. If it is severe illness, indoor patient and any complication, first line choice is the ceftriaxone, 100 milligram per kg per day. Maximum you can give 4 gram per day. Alternative line therapy when it is in hepatitis cases, the cefotaxime is used, and penicillin allergic cases, astronome is a drug of choice. On OPD basis, cefotaxime is used for around 20 milligram per kg per day, maximum 1200 gram per day. Azithromycin is alternative day therapy for 20 milligram per kg per day for 7 days. Still, there is a very less resistant to the ceftriaxone in the India. So, how we can prevent and control this salmonellosis? Simply by using clean and safe drinking water, hygiene during food preparation, and vaccination. Right now, typhoid conjugated vaccination is available, which is used above 6 months of age. The only single dose protection for 4 years, around 79 to 85% protection is given. Type bar conjugated vaccine is conjugated with tetanus toxoid. Only vaccine approved for the children less than 2 years. Till now, only single dose is recommended. Take away message to awareness about the cleanliness and hygiene. Vaccination is must and blood culture before starting the antibiotics. Thank you.
Thank you very much, Dr. Sunil. Very nice presentation. Now I request expert Dr. Vankar sir to give his expert comments.
Very good evening to all of you. Can you hear me, ma'am?
Yes, sir.
Yeah.
Sunil, stop
very good
sharing.
evening.
Karo.
Yeah. Hello. Very good evening to all of you. At the outset, I would like to thank Maha IIP and IIP Raigad for invite Dr. Amol Pawar, Dr. Ram Gopal, and Dr. Chitra ma'am for the invite. Thank you very much. I must congratulate Dr. Sunil Padalkar for his excellent presentation on Salmonella and enteric fever. He had very correctly elaborated all the points in the article, as well as he has made a good presentation about the pathogenesis as well as classification of the Salmonella species very well. And he has also highlighted good about the Indian data in this thing. So Salmonella infection continue to be a major public health problem all over the world, including in India, especially Southeast Asia and India are the most important zone where the Salmonella infection occur very commonly. Now, this article has a two-part, that is salmonellosis, which content of non-typhoidal salmonella, which is on the rise according to this thing. The non-typhoidal salmonella, which is mainly caused by either Salmonella enteritidis or Newport, or mainly maybe caused by Salmonella typhimurium. and most of the time it is 90% of them are foodborne. And very important to know about that this mainly causes travelers diarrhea or may be important cause of Salmonella gastroenteritis. The Salmonella gastroenteritis commonly occurs as a watery diarrhea. Rarely it may contain blood. It may have a nausea, vomiting, and abdominal pain. And rarely in the 5% of the cases, it may lead to bacteremia and metastatic complication. So the risk factor for developing Salmonella bacteremia are infants less than 3 months of age, and also those who are malnourished children, as well as hemoglobinopathies like sickle cell anemia or those who are immunocompromised hosts are at the high risk of getting Salmonella bacteremia or infections which are metastatic. The complications of this may include either meningitis, they may include septic arthritis, osteomyelitis, or as well as it can cause sometimes endocarditis. That most of the time in an immunocompetent individual, no antibiotics are needed. Only hydration is the only treatment which is needed for Salmonella, non-typhoidal Salmonella infection. But whenever it occurs in an immunocompromised host or it leads to it leads to a metastatic complications like septic arthritis, osteomyelitis, or meningitis, endocarditis, the long-term treatment may be needed. Routine treatment of just 3 to 5 days of IV antibiotics may be given in form of IV ceftriaxone. But sometimes with the meningitis, you require IV ceftriaxone for 4 weeks. But for endocarditis, you may require for 6 to 8 weeks. And for abscess formation and all, you may require for 4 weeks. There is no currently vaccine which is available at present for non-typhoidal Salmonella. So the only thing which can prevent is a good hygiene. About the second part in this thing is enteric fever, which he has highlighted very well. Enteric fever continues to be the major public health problem in India, and there is a growing incidence of various antibiotic resistance pattern. And as he has rightly pointed out, there is a resistance to the Salmonella typhi by the various drugs like ampicillin, chloramphenicol, and clotrimazole as a first line therapy has failed. And the second, fluoroquinolone also resistance is now developing very rapidly, and most of the Salmonella are now resistant to fluoroquinolones. Second important part is now various cases of XDR typhoid are there in the world, but they are mainly starting from the Sindh province of Pakistan, and then it has spread. But currently in India, we hardly have any much incidence of the Salmonella resistant enteric fever, which is resistant to ceftriaxone. So it is very important to suspect a Salmonella infection, and the clinical picture of the Salmonella typhi, that is enteric fever, differs according to the age of the child. When it occurs in a neonates as a vertical transmission, the picture can be entirely different. The neonate may come to you as a hypothermia or hyperpyrexia. They may come to you as a jaundice. They may come to you as a abdominal distension, vomiting, loose motions, or may throw seizures as a part. Second, when it occurs in the infants, they may commonly present to you as a simple viral infection like initially, but or may present to you as a fever without focus for more than 3 to 4 days. And then the child may have a cough, cold, coryza, abdominal pain, pea soup, diarrhea, nausea, vomiting, and all non-specific symptoms, and the spleen may be palpable at the end of the first week. Very important to know that when you take a hemogram, there may be a eosinopenia, but the hemogram is not very specific. And especially in neonates and infants, there may not be any leukopenia. In fact, we may find in many cases that it may show, leukocytosis, which is there in infants and neonates. That is important. And the blood culture is the most important thing and the most gold standard for diagnosis of enteric fever. And we should use more and more as a blood culture as a diagnostic tool. There is no role of much Vidal. Nowadays, Vidal is not used very commonly to detect the enteric fever. And because it does not, the positive Vidal test does not confirm the diagnosis of enteric fever, while negative test does not rule out the enteric fever. So Vidal is not a very good, neither sensitive nor specific test. He has talked about IgM typhoid. So that is typhidot test. That is, has got slightly better sensitivity as well as specificity than the Vidal test, but it is not at all a good test to detect the enteric fever at all. Lot of false positive and false negative results do occur. So a lot of discussion has already been occurred about this Vidal test, and also I will not go much in detail about it, but the gold standard is, and the only thing which can detect the resistance to the drug is a blood culture only. He has also talked about PCR test. The PCR test is also important test for detecting enteric fever. And currently at present, the PCR is useful as being expensive. It's not very commonly used test, and it can detect as many as 3 to 4 bacilli in the blood. It's highly sensitive and highly specific, but the important part is it comes positive in first 5 to 6 days only. Later on, the chances of having PCR positive are very less. Then the whole genome sequencing is also used as a mainly a research tool for detecting various antibiotic resistant pattern, and epidemiological importance is there. So these tests, currently we have this PCR test available as a multiplex PCR test in a topical panel, but not as only for Salmonella typhi. It may detect only a Salmonella species and not Salmonella typhi. So the treatment part of this thing, for all practical purpose at present in India, the drug of choice for uncomplicated enteric fever is third generation cephalosporin like cefixime 20 milligram per kg per day for the period of 14 days. When the cefixime, there is a resistance to cefixime or it cannot be given, the azithromycin is a drug of choice for treatment of the uncomplicated enteric fever as in a dose of 20 milligram per kg per day for the period of 7 days. If the defervescence occurs late, you may extend the period even up to 14 days for the azithromycin, because azithromycin, even if you stop early, has got a very good post antibiotic effect. That drug remains in the circulation for the longer time, and it is highly helpful. The defervescence period in azithromycin is less, that it is around 5 days, and the relapse rates are very less, around 2 to 3% only. So it is a very good drug, achieving very high intracellular concentration. But the azithromycin has to be preserved only for the resistant cases and should not be used as a first line drug. That is very important. For all the patients who require hospitalization and who are having a complication, for all practical purpose, currently in India, the first drug of choice is ceftriaxone only. The ceftriaxone or a third generation cephalosporin get highly concentrated, and they are very effective in managing enteric fever. The minimum defervescence period for ceftriaxone is around 6 to 7 days. So it takes time. So you should not worry about the resistance for the ceftriaxone, and it takes nearly 7 days for defervescence of the fever. There is no role of combination therapy at present for the typhoid fever, like ceftriaxone plus azithromycin or ceftriaxone for anything else. There is no role of the combination therapy, and you should be strictly following a monotherapy for treating enteric fever. When there is a case of drug resistant, the drug of choice may remain either, or whenever there is a therapeutic failure, like in 10 to 15% of the cases, there is therapeutic failure may occur, that even after giving the ceftriaxone is sensitive, but even after giving a ceftriaxone for 7 to 8 days, there is no fever defervescence or any complication occur, you may have to switch on to meropenem, that is as a drug of choice. But meropenem should be kept as a reserve drug and not should be used as a first line drug, because the rapid resistance to meropenem is also known. Another drug which is helpful is Astrionam in a dose of 50 to 100 milligram per kg per day for the period of 7 to 14 days. But that should be kept as a reserve. Those who are ceftriaxone allergic or those who are having those who fail to respond to ceftriaxone, the Astrionam may be the drug of choice for treating enteric fever. Amikacin, though shows sensitivity in vivo, it should not be used as a drug because the amikacin does not affect any intracellular organism. It cannot reach the intracellular. So no one should use amikacin as a drug of choice for treating enteric fever. Now the first line drug which were used like cotrimoxazole, ampicillin, chloramphenicol previously, now not being used, and again they have started showing sensitivity. But if we use cotrimoxazole as a first line, lot of allergic reaction do occur, and Steven Johnson and all it occur. So all practical purpose, we give cefixime as a first drug of choice. Chloramphenicol also is known to cause various bone marrow suppression, so should not be used as a first line. And for all practical purpose, we restrict to the third generation cephalosporin as a first drug of choice. And lastly, what I would say, because we are concerned more about the drug resistance, it is very important to prevent the enteric fever by good personal hygiene, good sanitation, and the most important of good vaccine. Very good vaccine is available to prevent enteric fever, and at present the IAP recommends typhoid conjugate vaccine above the age of 6 months, preferably in between the 9 to 12 months of age, as a single dose of a typhoid vaccine is recommended to prevent. So thank you very much.
Thank you, sir, for an elaborative guideline for the treatment of enteric fever. Now, may I request our convener, Dr. Jay Bhandarkar, to ask some questions if they are there in the chat box. Dr. Jay? Sir, my question is that you told about the signs and symptoms according to the age group for salmonellosis as well as enteric fever. So, what we understand by relative bradycardia and in which week it is present?
So relative bradycardia, which is there, is commonly seen in adults as well as adolescents. It is very rare to have a relative bradycardia in infants or young children. Relative bradycardia means for every 1 degree rise in the body temperature, the heart beat rises by around, or pulse rises by around 10 beats per minute. When this is not there, we call it as a relative bradycardia. So it is not, it is commonly seen in adults and adolescents, but not seen. So enteric fever has many more different features, like we may have that stepladder fever in adolescents and adults, but in pediatric age group, there is no specific pattern, and stepladder fever may not be seen that commonly in young infants. So whatever the complication that occurs in adults may occur in the 3rd week or a 2nd week, but in neonates or even in younger children, you may have a complication right in the at the end of the 1st week or the beginning of the 2nd week. So these are the differences which occurs in enteric fever according to the age.
Yes, sir. Thank you very much, sir. Another question is that in spite of getting 2 doses of conjugate vaccine, we do see culture proven enteric. So how to explain about that?
Yes, that is there, culture proven enteric fever. So see, any vaccine has got an efficacy. None of the vaccine has got an efficacy of 100%. So the typhoid vaccine has got an efficacy of say around 90%. So even in 10%, there may be a true vaccine failure which may occur. Secondly, we are seeing more of a paratyphoid fever which occurs in a child who has received even 2 doses of typhoid conjugate vaccine, because paratyphoid is not there in the vaccine. So true vaccine failure may occur in 10% of the cases, and paratyphoid fever also do occur as a part of it.
Thank you so much, sir.
I can add one thing, Dr. Chitra.
Yes, sir.
If
Yeah, please. Yes, sir.
If Dr. Sanjay permits, So I think that's
Yes,
why it
sir.
is important that even after one has a clinical or culture proven Salmonella typhi, you have to still give a
vaccinate.
vaccine. So it
Yeah.
is very important. And secondly, typhoid is a inoculum based disease. So even if you have a worst of Pani Puri, which is, full of a very high load, which the immune system is overwhelmed by this load, the vaccine may not be of any use. And as he said very rightly, that none of the vaccines are 100%, but then there is no recommendation to give a third dose of vaccine anywhere. Though there are controversies of one IIP, always ACVIP says 1 dose. Some people do give 2 doses, but never third dose.
So after proven typhoid, the child who has received 2 doses, we are not supposed to give the third
No,
dose.
there is no point in going just chasing that. Just tell them about improving the, as he said, prevention and taking care of personal hygiene. I think that is what important.
Yeah, right, sir. And then we do get more non-typhoidal salmonellosis in community kitchen timings, like marriage ceremony or some parties and all that thing. Please elaborate about that. Like what is the risk and for general public also, along with the pediatricians, to ask the history when the child comes with gastroenteritis or high fever.
So the salmonella, non-typhoidal salmonella are pretty common because of the poor hygiene. And see, the salmonella can remain in a water for around 7 days. It can remain in a ice cream for around, say, even 1 month. It may remain on flies for around 20 days. And it may remain in a soil which is contaminated with the sewage for around 2 months. So this is how it spreads very rapidly and through the either contaminated water and along with the contaminated food, water, it may also occur through the, so 90% of this salmonella, non-typhoidal salmonella do occur through the contaminated water and food, but rarely it may be a nosocomial infection or it may get transmitted from the animals. So that is there.
Yeah, thank
But
you,
the
sir.
carrier, excuse me, the carrier stage also lasts for more than 1 year, even though you were
Yeah,
vaccinated.
so it is very important to know that the carrier state in a typhoid fever occurs mainly after the age of 15 years, not before
Yeah.
the 15 years. It is very, very rare to have a carriers in a pediatric age group.
They are absolutely asymptomatic, but they have the carrier.
The incidence is even less than 2%. But when it occurs beyond 1 year, we call them as a chronic carrier stage. And it is very important to eradicate them. The drug of choice for all practical purposes is either amoxicillin, which can be given in a dose of higher doses, 100 milligram per kg for the period of around 2 to 3 months is required to treat the carriers. Alternately, we can give ciprofloxacillin as a drug of choice for a 1 month. And when the carrier state is commonly occur in the children who are already having some gallbladder disease at the time of having enteric infection. And when the drugs fail to eradicate this carrier state, then you may have to go for the cholecystectomy, which is rarely required.
Yeah. One more thing, sir, as a IIP guidelines, have you mentioned, the guidelines has basically what we follow is that when there is a febrile period for 5 days,
Yes.
last period of last day of fever, then we continue for 5 days. Either it should be 5 days more or 14 days, whichever the last longer.
Right. So whichever is the
not
longer.
every time you have to give for 14 days.
No, see, what the IIP guideline says, it has to be given for minimum 14 days. So suppose the defervescence occurs at 5 days, still we should give for 14 days. If the defervescence occur on, say, around 8 days, we should give for not less than at least 5 to 7 days from the period of the defervescence to complete the period of say 14 days. Why this is there? Because the relapse rates are higher if you give it for the shorter duration. So if you stop at around 8 to 10 days, the relapse rates are always higher.
And one more thing, sir. If there is a culture positive, either you give only IV ceftriaxone or you can shift to the oral cefixime.
Definitely, you can see the child becomes febrile and you want to discharge him on day 4 or day 5. You can complete the course of total 14 days by follow-up therapy with the fixing 20 mg per kg per day.
Yes, sir. Thank you very much, Dr.
Thank you.
Mankar. And there is a question for Dr. Upendra, sir. What are the guidelines for amount of fiber to be given to the children?
Yeah, so in general, when we talk about fiber, we do not talk about, none of the products that we talk about, we do not talk like this much fat, this much carbohydrate in day-to-day guidelines. Roughly, it is considered that adults should have about 25 to 40 grams of fiber total amount. But in pediatric age group, it is age plus 5. That is the amount of soluble fiber that and total fiber age plus 8. So suppose a child is 10-year-old child. So 10 year plus 5, that is 15 of soluble fiber. For total is 10 plus 8, so 18. But you would ask me then, how would I complete that 18 gram? It is difficult. So you can remember one or two, like 4 grams in apple or 3.3 in banana, but it's difficult to. So it is important to remember that one should have roughly about 250 grams of vegetables and 150 of fruits. So that is around 400 grams of vegetables plus fruits usually completes your quota of fiber that you need. So in every food plate that you have, half of your food plate should be of vegetables and fruits, and that will ensure that your quota of fiber is usually complete. All of us have been, today it was about cardiometabolic factors, but all of us know the most important, even tomorrow morning, we are going to have at least one patient, each one of us, who is going to come with recurrent abdominal pain, chronic abdominal pain, and who is going to be constipated and who has an extremely poor diet full of fiber. So all of us know that. So let's not lose an opportunity, not only adolescent, even young age, everybody needs to have some counseling about having good amount of fiber in their diet.
Yeah, thank you so much. Pallavi ma'am, any questions on YouTube?
No, ma'am, no.
Thank you so much. Now, may I request Dr. Neha to give away vote of thanks? Dr. Neha, are you there? Okay. So let me do that honor. A big thank you to immediate past Central IIP President, Dr. Upendra Kinjwadikar, sir, who has given his valuable time, along with expert Dr. Sanjay Mankar, sir, who has elaborated for the intricacies of treatment of salmonellosis as well as enteric fever and its complications. Our presenters, Dr. Sunil Padalkar, has done extremely well, and Dr. Narjohan Meshram, though intensivist, has given the small points of this research paper, which has enlightened our knowledge and understanding about fiber and the risk factors. Our mentor, Dr. Nimen Mohanty, sir, who has painstakingly found out the papers which are of public interest, and Maha IIP President, Dr. Ram Gopal, and Secretary General, Dr. Amol Pawar, who have given this opportunity, and they are carrying forward the Raigad IIP Child Journal Journey. Thank you so much. Thanks, Dr. Vikas More, sir, our Raigad IIP President, to be present here and taking keen interest in the journal journey. And now it is time for the comments of our MMC observer, past Maha IIP President, Dr. Ramakant Patil, sir, for the papers. I could see him typing the MMC points. Sir? Dr. Ramakant Patil, sir, may I have your valuable comments for the today's papers? Okay, we thanks for that. And our technical team, Dr. Neha, Dr. Vishal, and Pallavi ma'am, a big thank you.
Thank you, everybody. Thank you. Good night.
Thank you.